All right, so it's 3 past. Anyone joining after this might just have to catch up. We can kick off. It looks like there's plenty of people here at the moment. So thanks everyone for coming. Just to introduce myself, my name's Sophie. I'm one of the provisional psychologists here at Activate. And what I'll be talking on today is mainly trying to demystify the suicide risk assessment process. So I suppose to give a background as to where the topic of this webinar really comes from. We identified a real need to have an understanding of how suicide risk assessment is completed within our own workplace, managing mental health and working in a psychological space. And we thought it would be a good idea to share some of this knowledge with the wider audience, just to kind of demystify what really goes into a suicide risk assessment. So I suppose just to jump right into it, or before we do jump right into it, I do want to flag a couple of things ahead of time. So talking about suicide risk assessment and mental health can be quite a heavy topic. I want to encourage anyone, as we're progressing with the webinar, to check in with yourself as the presentation progresses and to take time out if needed. This can be quite a heavy topic, and so if you do find that any of the topics particularly are weighing on your mind, please do check in with yourself. If you notice anything's noticeably sitting with you during or after the presentation, I really do encourage you to contact Lifeline at 131114, your EAP provider if you've got one, or one of us at Activate. We'll be happy to support you. This is something that I will be flagging as we progress through the webinar as well. I really do want to make sure that that people's well-being as we progress with this, nothing's sitting with anyone. And towards the end of the presentation, I'll be providing these details again as well. I suppose as well, I do have the tendency to talk pretty quickly. So if anyone has any questions as we go along or wants any clarification, feel free to call out. Otherwise, there'll be some space towards the end of the presentation to answer a couple of questions. With the way that the webinar has been presented, I like to present pretty informally and have a bit of a conversation and make sure that we're walking through the topic together. But there will be a couple of points as well where I'll ask you to take some notes or have a consideration of what you might answer to a couple of questions that might come up and then bring those forward at the end. But let's jump right into it. So today, as you might be aware, we're going to be talking about suicide risk assessments. These can be considered quite stressful, complicated, and there can be a lot of unknowns involved in a suicide risk assessment. At its heart, a suicide risk assessment can be considered a series of 3 or 4 questions, ending in a yes or no question. Do we end the conversation, or do we need to call 000? This is obviously a really broad generalization. We're boiling things down here, but the aim of this webinar is really to try and simplify this really overwhelming process. So the suicide risk assessment process can never be perfect, but there are some core things to keep in mind that do make it easy to manage if you ever do find yourself in the position of having to ask yourself this question and making this decision. This webinar isn't a replacement for formal training such as mental health first aid. However, it's aimed at hopefully making this process less overwhelming and to try and give some clarity to people who might have a passing understanding of mental health but wouldn't really know where to start when it comes to managing suicide risk. Some of these skills can take some time to learn, and mainly what I'm hoping for is that 1 or 2 of the things I talk about here taken away with you rather than a perfect performance. As you might come to understand as we're progressing through the assessment, there really is no way to mess up a suicide risk assessment. There just are a couple of things to keep in mind that make it go much smoother and answer a lot of the broad questions that we've got. And I can understand what I'm saying here might not be doing too much to help with this feeling of being stressed or overwhelmed. It sounds like it might feel like there are a lot of unknowns involved in the process. So towards the end of the presentation, what I have done is I've gone a bit further in depth with some elements of microskills that can be used to facilitate this process. And there'll also, like I mentioned, be some space after the presentation to open things up if there are any lingering questions. But yes, I do want to emphasize that some of these skills can take some further time to learn. And I'm mainly hoping that I'm throwing a couple of things at the wall here and one or two things that I say make sense to you and you can take them away with you. So like I mentioned, this is a bit of an open forum. If you're not comfortable calling out, that's okay. But I do want to ask or raise the question to everyone participating here. If anyone's felt that they needed to assess risk, hold your questions for the moment. But I suppose in talking about suicide risk assessment, the first thing to really consider is, why would I need to do a suicide risk assessment? What indicates to me that this is something that's important to do? So starting the risk assessment is the first and most important step. And we start a risk assessment for a number of different reasons. Again, hold any call outs for the moment, but as I'm talking about this, um, you might be considering a number of different examples or situations where the thought has crossed your mind. And thinking about what indicated or what led to that thought crossing your mind is a really important way for us to identify where it might be appropriate to complete a suicide risk assessment, or where it might be appropriate to consider this. From a psychological point of view, in a given year, almost 30% of the adult population suffers from a recognized psychiatric disorder. Even further than that, in a given week, 10% of the adult population is suffering from clinical depression. So 10% being 1 in 10 people you might encounter in a given week. And even further than that, 1 in 2 people will go through a stage in life where they seriously consider suicide and struggle with it for a period of 2 weeks or more. So this is quite a concerning reality that we're really presented with. What it shows is that this is quite common. It's unfortunate that it is quite common, but it really demonstrates that there is a really great need for a broader social understanding of how to discuss suicide and how to sit with risk and how to acknowledge this reality and work with it, rather than, I suppose, to not acknowledge what we find ourselves faced with looking at these statistics. So when it comes to considering when do I do a suicide risk assessment, as I'm talking, consider if there has been any circumstances that you've encountered, and ask yourself what happened there and why did this question come to your mind. I do also want to flag at this point, if anyone has any personal experiences with this, check in with yourself, see how this is sitting with you, and of course, take some time away if you need to. In talking about what leads you to asking this question, that's what we would describe to be an invitation. So an invitation is a sign of distress that invites help. Invitations can be anything that a person may say or do that makes you feel like it's an invitation to ask something further. You can be wrong if it is an invitation, and that can be a good thing. So invitations look like many different things. I've got a couple of examples here on the screen, but they can look like someone saying, things feel really hopeless at the moment. Nobody understands what I've been going through. I'm really struggling. So those are some verbal invitations. Invitations can be nonverbal as well. You might have an understanding or a relationship with someone, and you might notice that they're not acting like their usual self. Or alternatively, aside from verbal and nonverbal, they can be things like life events. The most common invitations I hear before tricking onto really doing a suicide risk assessment in my practice primarily revolve around a big recent life event, whether it's experiencing grief and loss or managing significant stress. Alongside big life events are really feelings of being numb or isolated are really most common when it comes to having thoughts of suicide. Or on the other side of this, some people might be surprised to know that sometimes presenting as overly happy or overly engaged or presenting really quite positively with good reason to be feeling upset or overwhelmed can in some cases indicate an invitation to ask about mental health, how are you doing, or even a suicide risk. Someone has a really good reason to be feeling upset and they're masking that quite clearly, then that can also be considered an invitation. I do want to touch as well here what I mentioned about anything that, so I'm not sure if my mouse is coming up, pull a laser pointer up as well. There we go. So also just to underscore this, anything that the person may say or do that makes you feel like it might be an invitation. So someone can say something along the lines of one of these sentences maybe, I'm really struggling at the moment. And you can take that to mean a number of different things. Whether you take that to mean something and whether it is actually that are two separate stories. But using that invitation and then maybe following it through with considering, do I need to do a suicide risk assessment, is the important thing to make note of here. You can be wrong if it is an invitation or not. And if you are wrong, that's okay. That's actually, in most cases, quite a good thing. If someone says, I'm really struggling, and you ask further and they go, oh, well, it's really just on this level, but thank you for asking, is usually how things go in that circumstance. So if we're considering a circumstance where the question's crossed our mind and we've kind of laser focused on this circumstance and identified why is this question crossing our mind, or do I need to do a suicide risk assessment, calling these things invitations, the next step here is really to ask the question. So now we're going to be talking about how do I complete a suicide risk assessment, or let's simplify the process a little bit and demystify it. The first and really most important step to doing a suicide risk assessment is asking the question on the page here. Are you having thoughts of suicide? So you could even frame it adding this bit. You mentioned just now that you've been feeling overwhelmed and really hopeless. I want to ask, are you having thoughts of suicide? What I tend to find in presenting this is that there is a bit of uneasiness with the prospect of asking this question. So as I'm talking through this, have a think about how you feel about asking this question. If you have any concerns about what might happen if you say to someone, are you having thoughts of suicide? What do you think would happen? Often people find that it's quite uncomfortable to be in this position, and that's understandable. It would be an uncomfortable position, but at the same time, when it comes to doing a suicide risk assessment, there's really no way to escape this first and most important step, asking them, are you having thoughts of suicide? So talking about what concerns there might be with asking this question, there are a couple of common misconceptions. It's a really common misconception that asking about suicide may lead to someone acting on these thoughts. That's 100% not true. Going back to my point earlier, starting the risk assessment is the most important step, and we start by asking the question. It can be scary, but it's very necessary. And often what actually happens after asking the question is less scary than we might think. So it can sometimes feel as if asking this question might make the person feel ashamed, guilty, or angry. And that can happen. If it does, it's not your fault. You've identified an invitation, something that's really indicated to you that this person might be managing something, and you want to know if they are managing thoughts of suicide. If their response is negative to that, that's not on you. It really does depend on the circumstances, of course, but the long and short of it is you're asking because you care. What I sometimes say is, if the answer is particularly no, I'd rather ask the question, have you say, no, I'm not having thoughts of suicide, than I've not asked and have that answer be yes. And I suppose I want to frame this by saying I'm coming at this from a really a practice or a workplace sort of perspective, but even in an informal, maybe a friends or family perspective, it's still an important thing to come at. I'd rather ask the question and have you say no than not ask and have the answer be yes. And I'm sure that they would too, even if maybe there might be that discomfort. So this principle really extends to all sorts of things, like asking, are you okay? How are you doing? So things like, are you okay day have sprung up to really combat this perception that asking about these different things actually makes people feel not okay. Usually this perception is unconscious, and it's important to recognize if we do hold this misconception and to challenge that. And I suppose that's what I'm trying to do here by belaboring this point, is to say that if you feel like part of this discomfort with asking someone, are you having any thoughts of suicide, is because it might give that person the idea. That's not true. So once we've asked the initial question, are you having thoughts of suicide, there are a few core topics that are important to making the decision about safety and escalation. And this is the point where it can feel quite overwhelming. There are any number of different things that can determine how at risk a person might be. To boil it down and to try and demystify this process, the three things that we can break it down into broadly are whether there's intent to act on these thoughts, whether they have a plan to act on this intent, and whether they have access to means or access to this plan. So to go into this a little bit further, intent and having these thoughts are two separate things. So someone can say, yes, I'm having thoughts of suicide, but it's important to check in after if that is their answer. Have you acted on these thoughts, or are you planning to act on these thoughts? Many people have thoughts of suicide every day, as we might understand from the statistics earlier. Having these thoughts of suicide and actually planning to act on these thoughts are two very, very different things. And I suppose if you find yourself in a circumstance, are you having thoughts of suicide? Yes, I have. Do you plan to act on these thoughts? The answer can definitely be no. And a follow-up question to that could be, can you keep yourself safe until you see your psychologist or talk to your GP or engage with some sort of support? This is really the first point where talking about suicide gets confused. Is often we do find that, or we run with the belief that having thoughts of suicide means that they're planning to act on it and their safety is in my hands. And absolutely, you're now in a position of trust when it comes to completing this risk assessment. But it's important to, I suppose, divulge or separate these two things. So going down the list from intent, someone can have thoughts of suicide and have intent to act on these thoughts, but they might not have a plan, or this intent might not be imminent. So following on from having thoughts of suicide, maybe even having intent to act on these thoughts, we need to know if they have a plan or not. Someone can have thoughts and can have intent to act on these thoughts. If this intent isn't immediate, isn't happening right now, we can maybe ask, do you have a plan? Plans can look like any number of different things. In most cases, people would know how they could do it, but they don't have a particular plan of how they would act on these thoughts. And if there is no particular plan, then as much as obviously this person might be more at risk than if they didn't have intent, they may not be at imminent risk. The last thing on the list, and as you might notice as we're talking through, these questions lead into one another. So at the first level, are you having thoughts of suicide? At the next level, do you have intent? At the next level, do you have a plan? And one of the most important final levels is, do you have access to those means? In some cases, someone can have thoughts, intent, and a plan, but they don't have access to what if their plan might be. Obviously, as we go down this hierarchy, the person might indicate they're at more and more imminent risk. But even still, if someone doesn't have access to the means, then they may not necessarily be at imminent risk. We're looking at these factors. It's never perfect, but what we can do is do our best to really boil down what we've been told, or this conversation, this position that we've been put in, into a yes or no question to what we were asking before. Is this person in imminent need of safety, or are they safe enough to engage in support? Can we end the conversation, or do I need to call 000? The question of determining imminence is really the core skill behind following through with the risk assessment. And as I'm talking about this, I do want to ask you guys, I want you guys to have a think about the question. Do you have any ideas of what an imminent or not imminent situation might look like, or an ambiguous situation? Like I've been saying, this isn't a perfect process. Thinking about a couple of different scenarios, there may still be some ambiguity. And really the goal here is to try and limit that ambiguity as much as possible by having developing an understanding of different levels that go into this imminence. 1, whether there's thoughts of suicide. 2, whether there's intent to act on these thoughts. 2 most important things, I would say. 3, whether there's a plan. Still very relevant if the answer to the first 2 questions is no. And 4, if they have access to means. What I'm hoping in talking through this, and I'm hoping that this isn't really just coming across as me rambling. Call out if you do have any questions, or if there is anything you'd like me to clarify. What I'm hoping is that in considering maybe a circumstance, what I asked earlier, if maybe there's ever been a position where you've thought, I need to do this, or I don't know how to do this, what the invitations were, and then asking these questions, that ambiguity is hopefully going to be limited and limited and limited. So what to do next if we do find that things are imminent, if the answer to these questions isn't yes across the board, or yes to all of the more important circumstantial pieces. At the simplest level, if they're at imminent risk and can't keep themselves safe while they talk to you or until they engage with the support, then you need to connect with 000 and gently collect information. So this is framed again from the point of view of, say, things that activate, or in my practice, maybe over the phone. But you can also do this face-to-face as well. So if you're over the phone, you could ask the question, where are you right now? Or is there anyone else there with you as well? What I found in my experience is most often completing a suicide risk assessment or talking about these things happens most often over the phone or via distance, or maybe over a messaging service or something like that. And asking questions about where are you right now, or is there anyone else around you, can be a good way to engage in support if we find that things are pretty imminent. Or further onto those two questions. Is there anything you see around you, or what's your name? These are some really targeted questions. I suppose this is the point where, depending on the circumstance, you'd ask different questions. If it's a face-to-face, you could ask, where are you going to go from here? Maybe they're going to go home, or maybe they're going to act on their thoughts of suicide. In that case, connecting with 000, sitting with them, gently collecting information. So sitting in this space, if you find that you've asked these 4 questions and you've found that, wow, okay, I think this person is at imminent risk, sitting in the space can be incredibly difficult. Don't feel like you do need to control this person, or that you're responsible if anything happens. Again, that's a really common conception in considering what would I do if I'm in the position of having to assess suicide risk. Is, wow, I'm responsible for this person. I need to stop anything from happening. And if anything bad does happen, it's 100% my fault. Really, what you're here to do is to keep them busy, trying to help them feel heard, and trying to be a non-negative part of their environment. That's all you would really be expected to do reasonably in completing this process. And if you find that you're expecting more than that of yourself, ask yourself why that's the case, and maybe consider if that's really helpful here. Don't forget yourself in the process is really what I'm trying to say here. And say if this is happening at work, trying to flag down a manager or a person nearby, or if it's not happening at work, to quietly sit with you, and you can do that, then do so. So saving your questions for the end, I want you guys to consider how you would feel about being in this situation. What would your concerns be at this stage? Where does the ambiguity come from in your mind? Can you imagine a situation where someone might answer yes to all these questions, but not be at imminent risk? I suppose it's not a perfect process, and there is a million different variables that we can consider. But when it comes to determining imminence, I suppose my general approach is I would rather have escalated things. If I have the impression that they've answered yes to intent, they've answered yes to having a plan, they've answered yes to having access to that plan, even if maybe there's good reasons for them not to be in imminent risk. If there is that ambiguity there, then shifting things over to the let's do safety first. I would rather not take the risk. Let's connect with 000. Let's escalate things together. This is often the hardest position to be in, and this is more often than not the most common end result when it comes to completing a suicide risk assessment. The more common end result, if we found ourselves asking, are you having thoughts of suicide? And then maybe touching on these 3 or 4 different areas, is if things are not imminent. So like I mentioned earlier, many people experience thoughts of suicide every day. A much smaller number of people actually act on these thoughts. Don't be alarmed if someone actually does have thoughts of suicide. They likely do have reason to. Only be alarmed if they intend to act on these thoughts soon, or if they're ambivalent and tick all of the boxes. The primary goal in this space is to, if you're sitting with them, you've completed a suicide risk assessment, or you're completing one, and you're finding that things aren't imminent, but they're sharing this pretty serious information with you. The primary goal in this space then is to help them feel heard and understood. It can be really tempting to rush into linking them with supports, and they might be ready to, but if they're not imminent, be mindful not to offer advice or solutions at least too early. So what do you think you need to do from here is a good question to ask in that circumstance. I can imagine now, or I can understand that this might conflict with what I was saying just a minute ago about safety first. Let's make sure that you've got access to support, and that can definitely happen. But again, safety first might be a separate question from safety now. If you have 5 minutes, or if there's really no immediate happening right at this moment risk, then taking the time to sit with them, if it's not imminent, and asking them what they need can be a really helpful thing to smooth the process along. You won't be expected to solve their problems, just to listen and try to understand. And in most cases, they'll engage in coping in their own way once they're feeling heard and understood. So this is really the long and short of it. I can imagine this is a lot of information to convey. And so if there are any questions, make a note of them and bring them up towards the end. But I suppose after working through this a bit more, the ambiguity here is the big thing I want to try and tackle. The purpose of this webinar being to demystify suicide risk assessment. How much mystery is really still there? What areas do you still have concerns in? So I want to show this briefly. This is, again, not a perfect model, but this is something that I put together to really try and streamline the process of completing a suicide risk assessment. to try and make it into a bit of a decision tree flowchart. So to kind of illustrate this visually, we start up here in the top left. Are you having thoughts about suicide? The answer can either be no, and in that case, providing support. They might have given you an invitation to ask that question, and in that case, we could talk about what that invitation looks like. If they've said, I'm feeling really lonely or numb, how would you like me to help? Or would you like me to book you in maybe a more workplace or clinical sort of context? If the answer to are you having thoughts of suicide is yes, slowing down and asking, are you able to keep yourself safe while we talk right now? Or do you have intent to act on these thoughts right at the moment? If the answer is yes, I am able to keep myself safe, then again, we can go into asking further questions. If the answer to this question is no, I have intent to act on these thoughts, I can't keep myself safe at the moment, really escalate safety first. Let's just progress things then. So if they are able to keep themselves safe while they talk, they don't have intent, or maybe they do have intent. Do you know how you would act on these thoughts? Maybe they may or may not know. This is really the question when it comes to, do you intend to act on these thoughts? Maybe I could word that a bit more clearly in this graphic. If they don't have any intent, then maybe we can just progress things back to providing support. How would you like me to help? Again, in this sort of pathway, many people have thoughts of suicide. Many people don't act on these thoughts of suicide. Going back to here, if they do have intent to act on these thoughts, it's important for us to ask, how would you act on these thoughts? And do you have access to that? If they have a plan and if they have means, then we need to escalate to, is there anyone around you who could help? Or do we need to escalate things? But if the answer to this is no, again, someone can have thoughts of suicide. Someone can even consider that they might act on these thoughts, but they might not have the means to do so, or they might not have a plan to do so. And in that case, maybe to give an example of what this circumstance might look like, it could be someone who says, yes, look, I've been managing thoughts of suicide. I do intend to act on these thoughts, maybe in a couple of months' time, or a couple of weeks' time, or in a week time. Again, this is the shorter and shorter time frame indicates greater and greater risk, but maybe not necessarily imminent risk. If they're quite clear that I intend to act on these thoughts, not for the next week, then that may not necessarily be imminent. And in that case, we can provide support. How would you like me to help? Maybe we can provide more support than we were originally intending to do. And the final question being, is there any support that we can go to? If the answer is no to that, then again, contacting 000. So this red line here could probably come along here as well. So at the risk of talking about too many things and not really having much stick, there are many, many, many different microskills that trained professionals use to facilitate the suicide risk assessment. I do want to be mindful of not overwhelming people, so I've tried to highlight what I see as some of the most important underlying skills to facilitate suicide risk assessments, or even talking about mental health with people in general. Of all of the microskills I find helpful to keep in mind, the one most important main thing I suggest is do not rush. The problem at hand is usually not something practical, even if it might seem like it. It's more than likely the person's feeling isolated, feeling overwhelmed, feeling uncertain, or feeling distressed. And because of this, what they really need is to feel heard. Often, once someone feels heard, they do feel less isolated, overwhelmed, uncertain, or distressed, and then they have the capacity to make up their own minds about what they'd like to do next. People will likely understand their own challenges better than you or I do. Because of this, it can sometimes even seem minimizing to offer too much advice or solutions too early. Giving someone some space to listen instead and helping them do what they would want to do is really all you're expected to do here, particularly if you are a treating psychologist or a doctor or someone in that capacity. So again, to really highlight this, someone might be presenting with a number of different invitations. Like I mentioned earlier, an invitation could be a really big life event, managing grief and loss, or going through a lot of stress at work. And in that case, we can say, okay, we'll call in sick to your boss. Let's go do this. Let's go do that. Fantastic strategies. Maybe that's even in the end what they need to do. But if we hold those strategies just a little bit and try and listen, not rush into those strategies, help the person feel understood and heard, then we manage the real forefront difficulty that's in front of the person managing all of this, which is to to put some words to it: isolation, feeling overwhelmed or uncertainty or distress. And if we hear someone, if we help them feel heard, then that uncertainty is still there. There's not the expectation that you make them feel better while they're managing all of this, but it often goes to the background, and then they have the capacity to, that sort of thing. The final micro skill I want to cover is open or closed questioning. So keeping in mind, I've sped through this content, so there's going to be plenty of time for questions or going back over things that people would like to. But what we have here are 2 micro skills I find really important. If you've gotten through the process, you found, wow, this makes a lot of sense to me. I'm taking away information. I'd like to take away even more. 2 micro skills I'd like to put forward is understanding the difference between closed questions and open questions. So closed questions are asking things that are yes or no. To give you an example, closed questions start with, do you have, are you having thoughts of suicide? Do you have a plan? Have you acted on these thoughts? These kinds of questions can only be answered in a yes or no fashion. And what this ensures is that we really obtain a particular piece of information, primarily around safety or suicidality. Because then we know either yes, and then what do we do with that? Or no, and then again, what do we do with that? The disadvantage to closed questioning is that it can cause a person to convey less information. It does halt a conversation if we're asking a lot of, have you talked to this person? What about that? What about this? Or, have you done this? Is that happening? That can just lead us to a whole bunch of us talking a lot more and them saying yes, yes, no, 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 yes, no. And then it really interrupts the flow. Not necessarily a bad thing, particularly around safety, suicidality. And you're not in the position of doing this perfectly, or you don't have to be. So the next thing here, or in contrast, is open questioning. So this involves starting sentences with who, what, when, where, why, or how. If we start a question with what would you like me to do here, or how can I help, or who would you like to talk to, we can't say yes to those kinds of questions. Instead, it puts the onus on them to come up with an answer that's a little bit more elaborate. They can't be answered in single words, and they encourage someone into providing more information than they might have if it was a closed question. It's often a good coaxing tool. The potential risk with asking too many open questions is it's not as specific as a closed question, and it can let someone dodge the question, and it's mainly only concerned with safety and suicide risk. Practicing and learning how to identify when you're asking open and closed questions is a really fantastic communication skill to learn. And I suppose to really paint broad strokes here, if I were to try and underscore this process that I showed over here, oops, a bit too far, to underscore this process that I've showed over here, what the aim of the suicide risk assessment, if you find yourself in this position, is to ask closed questions until we have a certain answer on whether things are imminent or not imminent. If they're not imminent, then we go to asking open questions. How would you like me to help? Would you like me to book you in? Oh, that's a yes. Yes, that's a closed question. So we've all been in the position of being asked to say, how are you doing? And answering a general question with a general answer, I'm fine. It's quite a common occurrence. And as much as this is fine and normal, everyday part of our society, part of the reason things like "Are you okay?" day have sprung up is to change some of the language around how we engage with each other. Asking "Are you okay?" is a closed question, and we can either say yes or no. Obviously, we can still obscure that, but what that can lead us to do is to say no, and then we have a bit more of a certain piece of information. Or alternatively, asking an open-ended question like "How are you doing?" or "What have things been like for you?" allows the person being asked to disclose what they think is relevant. In the context of suicide risk, we start things with direct and closed questions for a concrete answer on where things stand, and then we look to get to a place where we ask open-ended questions and let the person we're talking with take things to where they need to go. So these micro skills are further explored in Activate's other mental health training. I'm pretty passionate about this particular area, so I hope that it doesn't seem like I've really overwhelmed you with all this information. But if you'd like to know more, that's something that we can definitely offer. So just in summary, I can understand this might seem like a lot of information, or maybe not to everyone, but Number one, being open to invitations, understanding what's involved in that process and trying to change your thinking around what an invitation is and incorporating that um, into your understanding of when do I need to do something like a suicide risk assessment. Um, Considering these things as invitations, indicators that someone's asking you to ask them further information can lead us to asking the question more. Asking the question is the first and foremost most important part of doing a suicide risk assessment. And if there was one thing I'd like you to take away from this presentation, it would be to just ask the question, are you having thoughts of suicide? Obviously, having some support with what comes after that is really important, but there's really the only way to succeed at a suicide risk assessment is to ask that question. The only way to fail at a suicide risk assessment is to not have asked that question. Following on from maybe getting a yes or no answer to, are you having thoughts of suicide, determining imminence, this can be a cloudy, ambiguous process, and it's not perfect, which I can understand might not be doing too much for the people participating here in managing that uncertainty or that stress. So I suppose to try and clarify that a little bit more, when we determine imminence, what we look for is intent to act on these thoughts, a plan to act on these thoughts, and access to that plan. In using this further information to determine imminence, I really want to convey that listening is helping. And some of the microskills that we've offered are really just there to facilitate listening, but you don't need to be perfect in acting on them to complete a suicide risk assessment. So just lastly, this has been quite a heavy topic. Check in with yourself if you find that some of this is sitting with you. A couple of resources you can access is Lifeline at 131114, or you can email activate@admin@activate.com.au if you'd like to check in with one of our EAP providers, or if you'd like to find out a little bit more about our mental health training, or you can call us at that number.